afternoon, everyone. Give me a great pleasure to start a new session now on V6, which is aortic disease. Also, I have a great pleasure to introduce Professor Muhammad Omar Farouk in Egypt. He will share with me the session. All right. Abdullah, you want to start, Abdullah?
Yes, Doctor.
Okay, well, let's go and start, please.
Okay. A 62-year-old woman presents for evaluation of her 5.6 centimeter abdominal aortic aneurysm, shown in the coronal computer tomograph. The patient strongly desires endovascular repair. The most appropriate management of this patient is.
All right, so she's 62 years old, correct?
Yeah, 62.
And the aneurysm is
aneurysm 5.6. So she is on, reached the target above 5 in female.
Correct. And male, how much male?
5.5.
Correct. So what's the problem with this one? How long is the neck?
It's 7 millimeter. We have short neck.
All right. Because what's the minimum neck required for standard EVAR?
IFU is 10 to 15 millimeter.
This is correct. So this is 7 millimeters, right?
Yes.
So what do you think the option of treatment with this short neck?
With short neck, we can use the multiple option. One of them EVAR with endo anchor, or she can go with the branch or fever.
Not the branch, because branch need a wide aorta, you see?
Yes.
Like thoracoabdominal. You don't do branch for juxtarenal. So also we do a fever filtrated.
Fever, yes.
Yeah, so the fever. Okay. So you said so the endo anchor is the option, fever is the option. What else?
She can go for open if she not desire endovascular.
Okay. Correct, open. What other one more in the vascular option?
Endovascular.
So you said endo anchors, fever. What the third option could be for short neck? Fever, right? Chimney.
Chimney, yes.
Correct? So this is all the options, either chimney, endo anchors, fevers, and open repair, correct?
Yes.
Everyone has a plus and minus, right? Which is the one has the most solid data for long, like patency and prevention in leak?
Which one of these? Most likely
the best has a solid data. Fever, correct. So the most solid one we have a good data is the fever, right? But what's the disadvantage of fever? If it's the best, why we have other option? What's the disadvantage of fever? So why we have like endo anchors? Why we have a fever? If fever is the best?
صراحة I don't know.
No, it's simple because it takes too long, right? It takes a long, like 3 months to get. It's the first thing. The second thing, it depends on where you are living, but it takes a long time. So it's not good for urgent or emergency cases. Patient comes like with ruptures or urgent or symptomatic aneurysm is not good for that, correct?
Yes.
And the second thing is the price is very expensive. The third thing is need a lot of technical skill. So you have to have a good technical skills to do a fever. So all of them, it goes against it. The reason why I have the other option, which is I said Shivar or endo anchors, which is good for emergency, good for urgent cases. Like if you by mistake you cover like subclavian during renal artery during EVAR, standard EVAR, so you have a choice to do a Shivar. And it's less cheaper, less technical skill demanding. But what's the problem with the Shivar?
Gutter endoleak.
Gutter endoleak, right? But the majority are, the good thing is the majority are benign, really. And if you look at the SOLT data, which is compare fever with the Shiva, really was not major difference in the mortality. Intervention was higher for fever, really. But the endoleak was higher for Shiva. But the long-term patency the renal patencies are similar. But even though still Shiva is the first choice, you know.
Yes.
What about endo anchors?
endo anchor يعني use only يعني of the aortic neck يعني shorter than IFU. It helps to prevent migration of the stent.
Okay. You know what the FDA approved for? What lengths for endo anchors?
Up to 4 millimeter.
Correct. 4 to 10, not up to. Start at least 4. You need at least
Yeah,
4
at least 4
to 10 millimeters, right?
Yes.
But again, they have to be careful when you look at this data because 4 millimeter is the neck, but you still need a sealing zone at 10 millimeters. So 4 millimeter alone is not enough. So you need to have 4 millimeter neck and 10 millimeter sealing zone. So you have to be careful when you say 4 millimeters. Endo anchors. So what the disadvantage of endo anchors?
Again, it is expensive.
Okay.
I
mean, some people, they question that it may damage the fabric of the stent. Some people argue is that because you make a hole in the stent, like you do inside of fenestration. Some people, they argue that if you get an infection, it's very hard to be taken out because you have endo anchors, you know, so make it harder to remove it, you know. And so it's still questionable. That is not very solid data. So really, the most solid data you have is fever and Shiva, but I'll still put the fever as the first option. And of course, open repair in a healthy guy is the best option when you have a short neck, you know. All right?
Yeah.
Yes.
All right. So let's see what now. So what they want. Let's see what the options they give us. Let's go one by one.
A, open repair. It's a choice, but the patient, she wants endovascular.
Okay.
Infrarenal endovascular aneurysm repair, EVAR, with commercially available device with fixation based on the aortic bifurcation.
You know what is this one they're talking about it? It's endologic. Okay. This one, the stent sit on the bifurcations. I don't know if you know this device, because all the other stent, the bifurcation is very high in the middle of the aneurysm.
Yeah.
So this way, this one is sitting at the bifurcation. They think that if you sit at the bifurcation, it stabilizes the stent graft, you know, and decrease the migration and indole. But really, it's never been approved because what happened when the stent migrates, they don't migrate downward, they migrate to the side. So you still get an indole, you know, if the neck gets dilated. Because aneurysm, rarely you see it straight, always you see angulation in the aneurysms. So even if you put the EVAR at the bifurcations, the EVAR will be twisted, will be like kinked, or will be like in a curved position. So when the blood comes, we're going to push it to the side, not down. So putting at the bifurcation, it doesn't help much really. It's just for like advertising, but reality did not prove that it decreases your type 1 indole later on if the neck gets dilated, comparing with the other available commercial devices. And it's more technically difficult because you have to pull the arm from the other side. You have to, you know, snare the wire and pull it down. So technically it's more difficult. And now rarely people use it, but it's there. But this is what they mean by device with a fixation on the aortic bifurcation. Okay, next.
Okay. The infrarenal EVAR with commercially available endograft with 10 millimeter proximal neck. It will cover the renals.
Say that again. Infrarenal EVAR was commercially available endograft with 10 millimeter proximal, but we don't have 10 millimeter here, right?
Yeah, it will cover the renals.
Right. So no, let's not cover the renal. No. They're saying that you want to use an EVAR, what's IFU approved for 10 millimeter. But you cannot use it here because the neck is 7
millimeter.
Yeah. So you cannot use it. Okay.
Endovascular repair with bilateral renal snorkel chimney. Okay. It's an option, but not the best. E, fenestrated repair with commercially available endograft. Yes, this is the choice. This choice for her.
Okay.
Upon her desire, I mean.
Right. If it's not her desire, what do you think is the best option?
I will go with open.
Yeah, especially 62, she's young, you know, and didn't mention any medical issues. So I think I will go with an open if is that, you know. young patient. Omar, I'm sure you have a lot to say, Omar.
I totally agree with all what you said. This exam is for first day consultant. So they know that you probably have just assisted in FIVAR, but you haven't done it yourself. So definitely open is a safe argument. Uh, all the data showed that FIVAR is the best option with the difficulty as you have mentioned. So this is an MCQ, so you don't have the luxury of explaining according to my experience. Is it what I prefer to do? So you have really to pick up your choice. But nowadays, with the amount of endovascular, 9 out of 10 aortic aneurysm in the United States is dealt endovascular. Open is really very, very minimal. A patient is anxious on endovascular. He did put this deliberately because he want to see how much you can discuss it with the patient, how much mutual agreement, and this is important when you discuss it with the patient. If this come to American Fellowship exam, I think E will be the correct answer. If this was, let us say, in the Middle East for Arab board, probably A will be the best answer. So again, there is no unified opinion. And I think the new young generation probably will be tempted to say more FIVAR than open. They probably have not done much open as you have done during your training, because you trained with Hazem al-Safi and you have done a huge amount of open, not just aorta, but thoracoabdominal. But I don't know what is do they mention what is the correct answer?
As I said, the E.
E. Yeah.
Frustrated, yeah.
Yeah. So
because this is what they want, because this is what we
exactly.
have a solid data. I mean, nobody argue.
Exactly.
I mean, but in real life, this is for exam is the right answer.
Exactly.
But in real life, it's different. Like in Middle East, will not be my FIVAR my best option because it takes forever, expensive,
Yeah.
And I goes into Anchor or Shivar,
Yeah.
Now people they start doing in situ what's the name? Physician modified fenestration.
Yes.
And I saw a couple cases, I think this is also been acceptable these days.
Yeah.
So sometimes you have to think about, but in Middle East, the first option really be an open repair, no question.
Yeah.
If it's just good health. If it's not
totally,
a good shape,
yeah,
then most probably I'll go with Shivar or endo anchors because FIVAR is difficult here, and unless if you have it, easy to get it, yes. But in real life, most probably goes open repair or Shivar or endo anchors. Yeah, 7mm is not bad really.
Yeah.
Yeah. All right. Any question before we go further? All right. Let's go to the next one. Who's with us? Bara? You want to take this one, Bara?
Yes, Dr. Samer.
Go ahead, please.
60-year-old male who smokes and has hypertension, present with an asymptomatic right popliteal artery aneurysm. What is the prevalence of an associated abdominal aortic aneurysm?
Yeah, this is a very common question. It's nothing to think about. You just have to know the data. So if you have a popliteal aneurysm, with a chance you have abdominal aneurysm. Just put a number. What do you think? Is high or low?
It is high.
Okay. So at least it's not the A, B, C. So you end with the D and E.
I think it is D. It is 50% of popliteal aneurysm, they have AAA. And around 15% who have AAA, they have popliteal aneurysm.
Correct. It's opposite, right. So you just have to know. So the reason why you have popliteal aneurysm, you have to look for aortic aneurysm. But when you have an aortic aneurysm, rarely we look for popliteal aneurysm because chance is very low, about 15%. But if you have popliteal aneurysm, it's very mandatory to look for abdominal aneurysm because 50% they can have it, what's the 85%? It's femoral artery aneurysm. If you have
I think iliac. If the femoral or iliac aneurysm with the AAA.
Correct. Yes, then you have a AAA. Correct. Again, it's not much about this question really. All right, well, let's go to Usama. You want to take next one, Usama?
Yes, Dr. Samer.
Okay, let's see this one.
Okay, a healthy 70-year-old man present with wrist pain in both his lower extremities. He had an endovascular repair of infrarenal aortic aneurysm several years ago with no follow-up. CT angiography obtained during his clinic visit is shown in figure 1 and 2. Operative mortality for late open conversion is most closely related to.
Okay, let's see what does he have first. Look, I think, let's see here. I think this is more obvious here.
Yes, yes.
So he has an EVA, right?
Yes.
But what else he has now? What the problem now?
He has stent fracture.
Separation here. I don't know
Yes.
separation because the coronal could be. I'm not sure because the coronal
Either
sometimes
way, if it is
you don't
not,
get the right.
if it is not,
But something different. What is that here? What do you see here? You see white and black?
Yes, it is embolic.
No, see black, completely black here, right?
Ah, yes, yes.
So it's clot,
Below the
right?
renal, yes.
So everything's thrombosed, right? You see even the clot here. So the whole thing's thrombosed now.
Yes.
Correct? So he has infrarenal aortic thrombosis.
Yes.
You see thrombus here. And the reason why they said he came with the leg pain.
Yes.
Because he thrombosed, you know? Both legs, thrombosed his aorta and the stent. So now you have, and even you can see it here. See thrombosis here, clot. And you can see the graft is collapsed here, and then thrombosed here, clot here.
Yes.
And you can see it here, very obvious. He has like at the level of the renal. He's like lucky. So he comes with a thrombosed graft and displacement also. You see how the graft is collapsed and everything. So it's like a big mess. I don't think it's any good endovascular option here. So the only way is to do an open now conversion, right? Take it out and do an open repair. So this is the question now. Now go back to the question. They said if you talk about mortality for late open conversion, related to what? If you decide if patient has like if you do a surgery, it comes with the EVA and you have to convert to open. Okay.
Yes.
Is the mortality higher or than a normal aortic aneurysm repair? What do you think?
I think it's to be higher.
Supposed to be higher if you do an elective.
Yeah.
If you think about it, really, it's not much. Why it should be higher? You know, you should put a clamp like an open repair and take things out and do aorto by FEM bypass, aorto by iliac bypass. The reality is not if you do an elective, you know, it's not much because you can work up the patient, you can do a good cardiac workup, you can do everything, you know, it's not like an emergencies. So the data show there's no different if you do for elective. But if you do an emergency, it's different because it's more complicated. As you see, complicated is more repair because you have a sac. Sometimes they have hooks. You have to take them out. It may take longer. You have to clamp suprarenal. Sometimes you have to go supraceliac, you know. So it become more complicated. Okay. So they want to tell you, they ask the question here, what operative mortality for late open converted to 2? What make it more operative repair? Why the mortality become higher after open conversion comparing with the normal open repair? Okay, this is a question.
Yes, yes.
So let's see options they gave us. The first one.
Yes, first one, elective versus emergency operation.
Okay.
Yes, as you mentioned to summary, the elective basis will be much easier, but emergency operations to be more difficult. But we'll see the other options. Presence of suprarenal fixation. I didn't see in the image there is a suprarenal fixation. I think it's the graft.
No, but I'm saying they want to ask you, is the suprarenal fixation make it? Now they compare with the open repair, you see? If I'm, you need to understand the question very well. CT angiogram, operative mortality for late open conversion is moderated. If you do late conversion, okay, so the conversion. If you do late conversion, you have to take him back for conversion. If you do have to do suprarenal fixation, does it increase your mortality?
Yes, because mostly I will close the suprarenal fixation, I will close both renals. I think it will increase the mortality. Yes.
But the suprarenal fixations, correct? It has nothing to do with that. I mean, you can cut the lead and you're not going to take them out. So the only thing you can do with your clamp is supraceliac, you know?
Yes.
It make it a bit more difficult, but it doesn't mean, I think, increase your mortality because you don't have to take suprafixation unless you have an infection. Here's no infection. You just have to cut it and leave the suprarenal fixations. Presence of concurrent endoleak. Do you think this affect your mortality or make the surgery more difficult?
I think presence of endoleak. No, I don't think so.
Will not affect it because just an endoleak, so you have to repair it anyway. So it doesn't matter if you have an endoleak or not. I mean, the repair will be the same repair. If the graft occluded, make a difference?
No, I don't think so.
Because you're going to take it out anyway. It doesn't matter if it's open or you see, all this doesn't make a difference really. Need for supraceliac cross clamping.
Also, I don't think
doesn't make a difference, but you see, a major difference is you have the emergency or elective. Like any open repair, even open repair, regular patient without conversion, if it's an open for elective emergency, it double your mortality than an elective repair, correct?
Yes.
So the same here. When you have the conversion for elective versus emergency, it increased almost double or even more. So mortality for elective, you know what? The mortality for elective conversion is like an open repair. It's about like 4%. But emergency, it may go like to 15%, you know, you have an emergency operation. So really emergency make a huge difference in the late conversion.
So I think there is the right answer.
Yeah. It's a bit tricky question. Omar, you want to add anything, Omar? I think he left maybe. All right, let's go to the next question. We go back to Abdullah.
Yes, Doctor.
Abdullah, is there? Yeah.
Yeah. A healthy 58-year-old man is referred to your clinic with asymptomatic aortic aneurysm. The patient has a large pulsatile non-tender abdominal mass on the physical examination. The CT angiographic image is shown in the figure. The most appropriate treatment for this patient is. So,
all right. Well, let's see what do you have here. Let me give a picture, good, nice picture here. Okay.
Yeah.
So you can see here is an aneurysm, correct?
Yeah.
The neck is 26 here. Okay. At 15, if you go down to 15 millimeters, the neck becomes 49. So there's no neck. So the neck is very, very short. You can see here, hardly you can see any neck, correct?
Yes.
Because if you need 15 millimeter neck, that is why they put this one. If you're looking for IFU 15 millimeter, and you measure aorta at 15 millimeter, it's 49. So this is not a neck.
Yeah.
So his neck only here, and you can see it here. It's very, very short neck, the aneurysm. Okay?
Yes.
I don't know how many big the neck here, but it looks very, very narrow, maybe 2 millimeters, something like that. I mean, they should give us a link here, but they did not give it to us, right? I didn't see it any place here.
Yes.
So this is the first thing. So the first thing, we have a very short neck, maybe 2 millimeters. Okay. Let's come to the iliac. Iliac 11. So 11, it's okay. 12.
Yes.
Okay. The external
iliac 9. Yes.
Which
fine.
Reasonable. Right.
Yes.
Let's go contralateral limb here. About 10. It's reasonable.
Fine.
Okay. And this is around 9. It's reasonable. So all of them are reasonable already. Okay. So all of them. So what's the question again?
But
the most appropriate treatment for this patient.
Iliac bifurcation, Doctor, 101, right or not?
Is that again?
Iliac bifurcation, aortic bifurcation, sorry, 101, right? Here.
No, this is the length. This is the length from here to here, it's 10 centimeter, yeah. They didn't give me the measurement here. I don't know what that was bifurcation. But two things you have to think, two things here very tricky. They said healthy, okay?
Yes.
58, okay? So what do you think the most appropriate? And patient has a short neck. So healthy guy, 58 years old with short neck. What's the best treatment?
Open.
Yeah, simple. It's open repair. Yeah. If it's not, then be a different story, but it's open repair. So let's see what they give us option. Let's go one by one.
EVAR,
And see
no,
why is wrong.
wrong
Because the neck
because,
is very short,
because
right?
out of IFU.
Correct.
B, open aortic aneurysm repair. This is a good answer.
Okay.
C, fenestrated endovascular. It can be, but not the best.
Okay.
Endovascular repair with use of endo anchor. No, we don't have a 4 millimeter neck or more. E, chimney with a snorkel or snorkel endovascular aneurysm repair. No.
They say what they said the most appropriate. What they said the most appropriate. You see?
Yeah, the most appropriate. She is healthy with more than 2 years life expectancy. So I will go
because open
with
repair,
open.
right?
Yes.
Right. But EVAR need at least 10 millimeters. So let's go about IFU. For EVAR, you need at least 10 millimeter, correct? 10 to 15. Okay.
Yes.
Fenestrated, you need at least for juxtarenal, you need still infrarenal at least 4 millimeter neck. So you cannot do it for without neck, you know. So IFU is 4 millimeter neck. They didn't give us here, but doesn't sound. It doesn't sound like 4 millimeters. It's very short, but they should give us the number. He didn't give it to us. The reason why fever is not a good option here. Endo anchor also need 4 millimeter, which we don't have it here. A chimney, you need at least 2 millimeters below the renals, you know. But again, in healthy patients, I don't think it's the best option. So I think I'll still go with an open repair. I agree with that. All right. Omar, you want to add anything, Omar?
Nothing much really after what you said, but the lower aorta looks very narrow. The lower limit of lower aorta for EVAR device should be 18 millimeter. It's just something to mention that in-craft device by Cordis is the only device which has not limit for the lower end aorta because it is so flexible. So you can do it even up to 10 or 12 millimeter lower aorta. And they said this is the only device that can be implanted in lower aorta. So there is multiple difficulties with this case that you did mention, all of them with endovascular repair. And the key to answer is a healthy 58. Then I totally agree with open repair is the logical option. It is not just, can it be done? Yes, it can be done endovascular. Is it the best option for this patient? We all agree that this will be a difficult EVAR case, and the long term, especially young with healthy arteries, longer term re-intervention will be very high. So I agree with open repair, and this is the thing that every device has advantage and disadvantage. Secondly, he did not mention some of the diameter, and this is a bit strange. Because if you want my opinion, you should tell me all the diameter to compare it to IFU. For example, the angle, alpha angle, beta angle, because the yellow line is the central alignment line. So this should be like computerized sizing, like endo size program. But there is some things that he didn't mention. Diameter of lower aorta, which looks very narrow, but didn't mention that diameter. So if I choose an image, I would choose a better image with all the information, because this I'm not testing you with the hidden information. This will be unclear question. But I totally agree with your answer. Yeah, it's very nice.
Yeah, I agree with you, Omar. They didn't give us the most important, the neck length. You know, they just put like a blue line.
Yes.
But he didn't give us really the length, and you cannot tell from this 3D.
Yeah.
So I think it's the most important part, the length, which he didn't give it to us.
Exactly.
Exactly.
And he wants you
like
to give
that, you know?
to give the final verdict of decision. So if it was me, I wouldn't approve this as a question, although it is VSAP 6. But if I'm reviewing this question, I will not pass it, because there is a missing information and you want the crucial decision making, but you didn't give me information to make this decision. So this is an important issue. Yeah.
That's true. That's true. And for the engraft, yes, I mean, we use it here, Omar, and
Okay.
even I saw it. I got a syringe, 10 cc syringe,
Yeah.
and I put the two limb inside and they
Yeah.
not compress.
Yeah.
And the reason, not the flexibility, really the reason why they don't compress, because they are the same size.
Yes.
You see, the
Yes.
both are same size, they don't compress. Where all other EVAR, the ipsilateral are usually larger than the contralaterals.
Yes.
So what happened? The larger one compresses the contralateral, but when you have them both same size, they will not compete.
Yes.
So they do very well.
Yeah.
But let me ask who was doing this question. So what other? Let's talk about if you are aortic like nerve. What other option? If you don't have an engraft, what other? And you want to do endovascular? What other options?
aortic أنا دكتور لك aortic
sorry,
aortic uniiliac وفم bypass.
This is correct. Yeah, this is option if you want to do it. Still want to do endovascular.
And welcome,
Yeah.
Dr. Muhammad from United States. He is with us in the car. I think he's driving
really?
toward the hospital. Yes, and
Yeah,
it is
Muhammad,
not.
please,
It's not an auto
anytime.
drive. You should buy Tesla, Dr. Muhammad.
Well, I don't see his name. Is there Muhammad?
Yes, his iPhone 2 is his nickname.
Oh, you know him, mashallah.
Yes, yes. I recommend him
iPhone 2.
to buy Tesla S model auto drive. Then you can have this Zoom with us while you are in the back seat with no problem, Dr. Muhammad. But he is driving, so you are muted, Dr. Muhammad. Don't worry.
Yeah, we don't hear your voice.
Secondly, one of the beauty of Incraft, as I know, it's the only device that you can do in case of iliac occlusion. I have done it in one case of iliac occlusion. There was, I think, right iliac artery occlusion. So you recanalize it, you balloon it, you dilate it, and you put an Incraft. And this is not an out IFU for Incraft. Incraft got an IFU to be used in iliac artery occlusion, which is unique. Now you can speak, Dr. Muhammad. You're unmuted.
Yeah, I'm not driving, by the way. Hey, you guys can look. So
okay. Okay, that's good.
So with the there's I don't know. I came in late to the conversation, but typically, you can use. There are two different techniques for narrow bifurcation. So it depends how bad it is. If it's 1 centimeter, obviously the best thing would be AUI.
Yeah.
If it's more than between 1 centimeter and 1.5 centimeter, we can use devices like Endologics, where it's designed for narrow bifurcation. You can put the device higher up.
Yeah.
You can also use a technique with low profile device such as Ovation and stent.
Yeah.
IVIS, the bilateral iliac can do kissing stents. You can do it open as well, with this. But that's an important consideration, and that's an important cause of limb occlusion, acute limb occlusions also, and if you don't do it right. So
yeah,
it's very important. Once I do this, I usually IVIS both limbs, make sure they're okay.
Yeah.
So, but yeah, so.
Sometimes if I'm worried about one of the limb is too small, I put a stent inside the limb to keep it open,
sure.
Self-expandable stent. I think it's when you have such a king and when you see the flow in that limb, you're not very happy with it. A stent can make you much happier. And I think when I started, we all have seen acute limb occlusion with multiple devices, but when I started using, let us say, self-expandable stent freely in kinked limbs, this decreased dramatically.
Yes, I agree with that 100%.
Yeah.
And if IVIS is available, it's a good practice for these cases, for just the iliacs. It shows, because when you look at the angio, it shows like a 2D dimension. IVIS gives you 3D dimensions that give you the narrow, the lumen, and all of that. So
yeah.
And when I used to, one of my mentors, we didn't have IVIS. He used to either put a balloon with a low inflation or would they check pressure gradients with these cases. So
yes, absolutely.
Yeah,
absolutely.
I mean, other options. I mean, if you have like a borderline, like 15, 16 millimeters, and no much calcification, and this is only your limit factor for EVAR. I mean, you can do an EVAR, and after that you balloon it, and then you can put a balloon expandable stent, the bifurcation kissing stent.
Yeah.
Or you can
Right.
crack the bifurcation, but after you put a stent, not before. Because if you
Yeah.
do it before, you may rupture the aorta.
Yeah.
But after you do an EVAR, you have more like balls to balloon the bifurcations and put
Absolutely.
the balloon expandable stent. If this is the only limit to do an EVAR. If he has multiple like problem like angulations, you know, not a short neck, then just go with an open and that's it. Yeah.
Yeah.
Yeah. It's like the case that I saw
Alright.
you guys have up. This is probably not an endocand. I mean, it's not a straight candidate case. Probably short neck, you know,
Yeah.
needs
Yeah, that's true.
needs something
And a
else.
healthy guy, is a healthy guy, 58 years old. So already the
Open.
best option is done open. Yeah. Yeah, I agree. All right, let's go next questions. Me Bara Mana. Bara. Bara, are you still there? All right. Usama, can you take Usama?
Yes, Mr. Samer.
Go ahead, please.
The anatomic factor that will limit suitability of penicillin into vascular repair for abdominal aortic aneurysm. بالراحة.
Go ahead. We'll
Yes,
come back.
aneurysm using correct commercially available FDA approved stent grafts is. So he's
Yeah, this
asking
is
about the
number. You
anatomic
have to know
factor
what the
that-
FDA for fever. So let's
Yes.
go one. So which one is what they said? Limit. So this is contraindications. I mean, limit suitability. So that means what is the contraindication of this one for fever? Let's go
Yes.
one by one.
Infrarenal aortic neck less than, 4 millimeter. This is, I think it's an indication for fever.
Yes.
Efficacy. We discussed in the previous case. Angle less than 45 degree relative to the long axis of the aneurysm. Not sure about this one.
It is. No, it is. Yeah, it is.
Yes.
I feel. This is called an alpha. This Omar, he mentioned that alpha and beta. You know, so for less than 45.
Yeah. That's right. Yes.
Long axis.
Yeah.
Yeah, and beta when you have it for suprarenal aorta.
Yes.
Should be less than 45. So both are correct. Should be by IP should be less than 45.
Okay. So third one, angle less than 45 degree relative to the axis of the suprarenal aorta. This is also an indication.
Yeah, man, correct. Yes.
Yes.
Okay.
The ipsilateral iliac landing zone, 18 millimeter in diameter.
Okay. I mean, what the largest limb? This is for fever, for cook, you know. So the largest, they come 24. So you have up to 22, you can use it because they have a limb go up to 24. So I think up to 22, you can do it. So 18 is acceptable. You can put like 20. It's acceptable.
Yes.
Okay.
Main renal artery 7 millimeter with bifurcation 12 millimeter from the origin.
Okay.
This one should be the right answer to this question because the main renal artery 7 millimeter it is considered
It's good
big
size.
artery.
Yeah, it's good. 7 millimeter laxum. We'll be happy if you have 7 millimeters. So what's the problem? The bifurcation, 12 millimeter, right?
Yes.
From the origin. So you only have 12 millimeter to land your stent, which is short. It may come out.
Yes.
You know? So need at least 15 to 20 millimeters to get really landing. So early bifurcation of the renal, or if you have multiple renal, is contraindications. Or out of ICU, not contraindication, but it's not an ICU for FDA approved fever. So for the iliac, you need at least, what the links you need in the iliac at least, you know? For EVAR or fever. The links in the iliac. You need at least like 3 centimeters.
Yes.
3 centimeters, okay? 30 millimeters. So the links at least should be 3 centimeters. The width should be less than 22, be acceptable. Angulation, as I mentioned here, you still have infrarenal neck 4 millimeters. But the most problem really with fever is if you have multiple renal or if you have early bifurcation. This is the most limit factor for fever. Ahmed, you want to add something to the fever? You do a lot of fever care.
No, you covered it pretty well. No.
Okay, yeah. Rafat, anything, Rafat? Okay, hopefully you didn't have an accident. Just kidding. All right, well, let's go to number 6. Bara, are you back?
Yes, Dr. Samer.
Okay, let's go to 6.
Yeah, so
The
my
most
point was,
Mana,
yeah,
Rafat?
you covered it pretty well.
Yeah,
just
what
one
about
thing
the
I
renal
can add.
bifurcation? What do you need at least the renal? How much it has to be the distance for the renals
Re-
from the origin?
Renals, the IFU is like, 4 or 5 millimeter. I do fevers, now, if it's less than 1.5 centimeter personally, but the FDA, it's probably 0.5 millimeter, 0.4 millimeter. So it's just aneurysms.
Right.
But there's a lot of
But
people doing it.
Go ahead, sorry.
There are a lot of people doing, now if you have a borderline neck, and it's somewhat controversial, but most people who do a lot of this, they do fever pretty liberally. If you have, 1.5 and less, or 1 cm and less, and you can do things like anchors and things like that. But then the concept of a neck degeneration, something like that. And the other thing is, I was going to add also, what I have done in a lot of cases also, and some people do it, many people do it. If you have iliac that's short, you can put iliac branch device and then do fever also on these patients. So you can buy a little bit of a landing zone with that.
That's nice.
So it depends on what each case, but there are technology available, and you can stage these cases. You can do, one thing one time, and then you come back and do the other thing.
Right.
So
right.
I agree with your point, Samer. Yeah, the difficulty is in the bifurcation 12 millimeter from the origin, which is just 1 centimeter from the aorta, and the renal artery usually does not divide into 2 branches. Sometimes it divides into 3, 4, and 5 branches. So this is the most difficult one. I probably would not worry about 7 millimeter renal artery, but I will worry very much about the 12 millimeter distance from the aorta. This I am hitting a problem, and I have seen people just ignore it and close 1 or 2 of these branches, and they get renal infarction, and it is not fun to deal with renal infarction post fever. Yeah, I totally agree with you. This is the I think E is the correct answer.
Yeah, this is the most limiting factor, because other factors you can always go around them.
Yeah.
As Muhammad said, but this is the difficult part, which is really limit your fever.
Yeah.
All right. So let's go to Barak. Let's go to next number 6.
The most appropriate use of endo-anchor as an adjunctive technique to repair infrarenal aortic aneurysm is to prevent type 1A endoleak in patient with aortic neck thrombus.
Well,
I think we cannot.
You think?
We cannot use endo-anchor with the neck thrombus.
Correct.
To
Why
prevent type 1A.
No. Let's start one by. Why you can't use the thrombus?
You need a healthy aortic wall to fix the anchor into the wall.
Right, because if you have thrombus, then the anchor will go inside the thrombus, will hold nothing. You need to get to the wall. And the thrombus will be pushing the graft away from the wall. So if you put your anchors, will not reach the wall to fix it. It will be like useless. Correct?
Yes.
Okay. You know how much the anchors goes inside? What's the distance? What's the distance between the aorta and graft should be?
You should have no distance, but I think the anchor should go at least 4 millimeter into the aortic wall.
The length is 4 millimeter, but reality you have 1 millimeter is a fabric, correct? And 1 millimeter will go inside the aorta wall, right? So the distance between the fabric and aorta wall should be less than 2 millimeters, not 4. You get my point? Because
the whole length of the
anchor.
anchor.
So with the anchor you put it in,
yes.
You're going to lose 1 millimeter the fabric, 1 millimeter in the aorta, because you're going to anchor the aorta. So the distance should be less than 2 millimeters. If you have more than 2 millimeter distance between the aorta and fabric, it will not work. Okay? This is very important. Okay.
I would
Let's
just
go to B.
mention that Samer was the
Yes.
first one in the Middle East to take the trip to Indo
Endo
Ankara.
Ankara,
Was a company called Optius, and Optius he
Yeah.
was fascinated with the idea, and he went to this company and he attended multiple workshops. And I remember he came to me. He was very excited with the new technology. And I think a year later, Medtronic have bought it and call it Indo Anchor. So if you
That's
want
true.
to ask anyone in the world about Indo Anchor, Samer is the one to ask.
Not like that, but thank you. Thank you, Mohammed. But yes, Endo Ankara we use quite often. Okay, next one now, B.
Prevention of type 1A endoleak in patient with calcium-laden aortic neck.
Okay.
I think it is also contraindicated when you have a heavy calcification at the aortic neck.
Because the same thing, because Anchor will not go through.
Yes.
Okay. Okay.
C. Prevention of type 1A endoleak in patient with short neck anatomy.
Mhm.
This is maybe correct.
Okay. Let's go to the next one. That's why they have it.
D.
You know what the
Treatment
neck,
of
the shortest neck they need to have for endo ankles?
4 millimeter.
Yeah, so you still have need a 4 millimeter neck. If you don't have it, you cannot do it, okay? So you still have need 4 millimeters. Okay?
D. Treatment of type 1 endoleak in endograft with infrarenal but not suprarenal aortic fixation.
You know,
I
so
think
what
we
you're
can
saying,
yeah.
Mhm.
I think we can use it with the devices that have suprarenal fixation. With short necks, 4 millimeter, still we can use the endo anchor.
It's really, endo anchor has been used with all devices, suprarenal, infrarenal, everyone, except one device you cannot use it. You know which one? She's out of the market now. It's out of the market.
I don't know.
Nelix device. Because Nelix it has, correct me, right? Nelix, Muhammad. Because it has what's called the sac filling. So if you put an endo anchor, you may puncture the sac and then you get a leak.
Yeah,
Correct?
the endo bag.
Also,
Yeah.
also the endologic device actually you cannot use anchors for because they use PTFE essentially, and it can be used in PTFE. But pretty much
Okay.
all devices you can use endo anchors. So
Right. Okay, so let's next one now. Muhammad Rafat, do you use endo anchors
yes,
instead? Because you do a lot of, really? Because I thought you don't use much because you have a lot of fever. You don't need it. You use it?
yeah, I don't use it. I've used it in before, and one patient. Again, this is personal bias. I had one patient had a dissection all the way, type A dissection, and we could not get him off the table. So I stopped using it back then. But that's one off case. But if you want to look at the data is pretty good for
So
endo
you think the
anchors.
endo anchor caused the dissection?
Yeah, you know, we have deployed it and probably was maybe calcified. I don't know. We caused just retrograde dissection all the way to the type A dissection. You know, you know, we got the heart team and we could not get him off the table. You know, he died basically from that.
Yeah,
But
I know what happens. Yeah,
and
well, we
that's
can
just
talk about.
personal.
Yeah, I don't know if anything mentioned. This will be a case report because this is because we use in the aortic arch.
Yeah.
But some people they question this one. They're afraid about it to get dissection, as you said. But I never heard about the first time I heard about to get dissection.
Yeah, it happened to me, and I'm terrible about writing things up, but it's too busy. But in general, like the data is pretty good for anchors. You know, I use the finasteride pretty liberally, but there's a comparison, for juxtarenal aneurysms with the appropriate neck, and the data is pretty good, pretty comparable. And it's what you're comfortable with and what you're available. And using it in the thoracic, I definitely, I think if I have to use it in thoracic, I probably would use it in the thoracic aorta because it's a good technology that and it has a good data actually. So
did you report
dissection?
Yeah.
I will not use in dissection because dissection is aorta is very fragile. I'll be really
not dissection.
Yeah. Did you report this case to Medtronic, Dr. Muhammad? retrograde
We did.
dissection with endo anchor?
We did. I never heard from them. I don't use Medtronic a lot. You know, they don't like me. So, but I
Okay.
haven't really.
Because
I haven't heard anything from them. So.
they have a big series now of endo anchor in Europe, world data of endo anchor, and they concentrate on the I wouldn't say absence of dissection, but the minimal amount of dissection reported, because some of dissection they found that it was not in the endo anchor point, but in between endo anchor points. So they now called EVAS technique or endovascular aortic sealing, which they think is that endo anchor will be mandatory to all devices. This is not the feeling in the States, but in Europe, if you speak about Germany, France, and Belgium, they do use endo anchor in a huge amount. This was the paper said.
Yeah, and you know, it's definitely. I can look it up and see follow up with them. We reported to them, you know, and that was several years ago. But I mean, that shouldn't deter anybody from doing it. You know, it's what you're comfortable with. Yeah. It's data absolutely great for anchors. You know, for when you use it right in the right patient. I think so. There's good data for it. So I think it's comparable. I just, my philosophy, you know, now we're doing more 4 vessels than 2 vessels, you know, for borderline aneurysms, you know. So we're doing more. We're going up from the get-go, you know, and we have a pretty good remodeling rate with this, you know. So it's controversial, but that's how I practice, you know.
Yeah, and I think also it's important for the staff with us that you should have training before you put endo anchor, because it is not just putting a screw. There is a certain views, a certain way of triggering the application. You must measure the distance. You must be sure how to put it, and you need really to get, I would say, 1 or 2 courses of endo anchor training before you start using them. And this makes quite a big difference if you use it under knowledge of imaging, how to do it, what is the triggering point, how to get flexion of the catheter, and how to put it. This makes a big difference in deploying it. I'm not sure if Samer will do such training courses for you in endo anchor. It will be very good really to do it. Even you can do it online.
I agree with you, Muhammad. As you said, I mean, training is the most important. Like any other devices, if you do it right, then you get good result.
Yeah.
Like even Shivar, I mean, if you do it right, you get a good result. People, they get a bad result when they don't do good. You don't do it right, you know.
Yeah.
And any technique has a lot of tips and tricks.
Yeah.
So if you don't follow tips, but if you do tips and tricks right and deploy it right, a very good result. But when you don't do it right, even for Shiva, if you do it really right, you go with IFU and you get a really excellent result.
Yeah.
But people who do it like right and left without following any protocol, the people get to trouble.
Yeah.
Let me add something, Dr. Samer, if I may, about Chivar. So Chivar has been shown to be a very good technique for 2 vessel disease. So if you have, like, if you do 2 stents, it's comparable to fenestrated. It's maybe the fenestrated showed a little bit more better, slightly better, but it's not statistically significant, but more intervention. But Chivar is a good technique for 2 vessels. But when you start getting, you know, 3 vessels, 4 vessels, that's when that's the data shows that the outcome is not very good. And now, you know, we have in the United States, they just approved a device called TAMPI, which is a branched, short branches Gore device. It's been used like crazy now. Everybody's using it for that. So, but for, you know, Chivar is a good technique to know. It will save you in the middle of the night for a problem, or it will save you if you cover the renals or something. So it's an absolutely good technique to know, and it must know actually. So for anybody who does endovascular. So, but I just wanted to add this so the followers don't know. You know, that's something that should be known. You know, so
that's true. Thank you, Muhammad. All right, well, let's go back to Osama. Or we'll go to Abdullah. Abdullah, go back to Abdullah.
Yes. A 77-year-old woman who is a heavy smoker with multiple comorbidities is being evaluated for fenestrated branch endovascular repair of her 7.1 centimeter thoracoabdominal aortic aneurysm. There is significant amount of thrombus, aortic wall thrombosis. A thrombus is associated with an increase.
Okay, so you can see thrombus here. Okay. You can see some thrombus here. So what they try to ask you is that if you have a thrombus, how's it going to affect what, right? Thoracoabdominal aneurysm during a fever, and you have a lot of thrombus. So this will increase what? Is your mortality, the cardiac, which one you think is going to increase your thrombus? Let's go one by one, Muhammad.
Okay, operative mortality.
Do you think thrombus has nothing to do with operative mortality, right?
No.
Okay.
B cardiac complications. Yes, maybe this one. But
how is cardiac complication? If you're going to emboli, you're going to emboli distal. You don't go emboli backward.
Yeah.
So
C
I
limb.
think stroke. You can tell me stroke, yes, but not cardiac complication, no.
Yeah. C limb loss. D solid organ infarction. I think D. Yes.
Yeah.
Late mortality. E. I will go with the solid organ infarction.
Yeah. This is a weak question, but it's not very good questions because I don't know what the idea from these questions. But not limb loss. Yeah, embolized limb. Yes, you have a free chance limb embolization, but not loss because most of you can do embolectomy. So the solid organ infarction, yes, you see it mainly in the renal, in the spleen, you know. So if you do fever with this embolization, with this, you know, heavy clot, you enter with the embolization. So be very careful, you know. So it's not nothing in this question. It's not waste a lot of time.
Yeah, the last question, I think, yeah, this question, to answer it, you need really to have read the Dietrich paper. Gustav Dietrich, he published a very important landmark paper in dealing with thoracoabdominal aneurysm with thrombus. And he mentioned, I think in his series, around 200 or more than 200 cases, Gustav Dietrich. And I remember I have read it, and it was fascinating because you cannot predict or think about the answer. If you haven't read this paper, it was quarter of them have organ infarction. It doesn't look what you would think of if you have a thrombus. I thought it will be more distal embolization and limb loss if I think about it. But in actual fact, what he faced as a problem with the thrombus out of his experience of 200 cases is solid organ infarction. So D is the correct answer. And if you haven't read Gustav Dietrich paper about the impact of thrombus in thoracoabdominal aneurysm repair, more than 200 cases, you wouldn't be able to answer this question. It doesn't come by logic. It doesn't come with what you have seen, but it comes by fact. And as far as I know, this is the only paper for thoracoabdominal aneurysm assessing the outcome with thrombus. So this is one of the questions that really tests your knowledge and how update your knowledge is, but it doesn't test your logic or your common sense. So this is a good question for knowledge.
I totally agree. That's also been our experience. You know, these patients with shaggy aortas, sometimes you have to do endo.
Yeah.
They get solid organ embolization. I've had a patient had liver failure from just doing a fenestrated, graft. So you have to respect shaggy aortas, and if you can do them open, even open, you can embolize too. So you have to be very careful. It's not a good case by any means when you have a thrombus or shaggy aorta, basically. So
I think that's embolization is very high, but clinically one is low, I think.
Yeah.
But if you do a CT, you can see a lot of trash. But luckily, majority we don't know about them. They are, and they are like asymptomatic.
And it depends on the technique, So you minimize, wire manipulation. You minimize catheters. You just try to do things one time and get the best guy that in the room that does these, do them, because it's difficult. You don't want to manipulate. It's manipulation basically. So I think
Yeah.
That's true.
a lot of it.
There is a very nice book to junior staff which come every year. The most important vascular paper in year 2023. They collect 50 paper. They issue this book every year, and they put the most significant paper that you should read. They are around 50. I will try to send it to Samer. I think I have the book for 2022, but I will see, because in 2023, I think it must include this paper from Gustav Dietrich about the thrombus. And I think it was 24% of the patient has solid organ infarction. So this is a very good book to read. You don't need to read every paper. You don't need to read every magazine, but at least per year, there are 50 papers that affect our practice. They are collected in a series which comes every year. And I will look around. I will see if I was able to get the 2023 digital format and send it to Samer, hopefully to put it in the group, inshallah.
Yeah. Thank you, Muhammad. Really appreciate it. Yeah. I used to read this one a long time ago when I was fellows.
Yeah.
I don't know if they're still doing that.
Yeah.
It's very good. Yeah, it's a very good book, really. Yeah. They summarize all the important paper from the last year.
Yeah.
All right. Well, let's go to 8. We go back to where now? Whose turn? Yeah, Abdullah or Osama?
I can take this question to Sam.
Okay, take this one.
Okay. 72-year-old man underwent endovascular repair of acute type B aortic dissection with placement of thoracic endograft. 2 days later, he complains of sebaceous pain. He undergoes CT angiography. This finding associated with.
Okay, so what do you think here? What do you see?
I see
This is
aortic
arch?
dissection. Yes.
Mm-hmm. What is that?
Aortic dissection. This is the arch.
Right,
And,
this is ascending aorta. This is the
yes.
arch, right?
Yes.
So they put a stent here, and you get dissection this way, backward.
Yeah.
And the ascending aorta. So what do we call this one? Retrograde type A dissection, correct?
Yes.
Yeah. This is the most dangerous thing. This is the most thing you worry about. And I saw a case after we would attend exactly type A dissection. And the same what happened with Muhammad. She never made it, she died on the table. And Muhammad Rafat, he just mentioned a case the same. So when you get it, especially when you get an acute on the table, rarely you can save this kind of patient. So you have to be very careful. So the question now, what the most common reason, what's the risk factor for type A retrograde dissection after TIVA? This is the main question. So I think it's an important question,
Yes.
You know what, before we go, you know what the answer? What's the most common?
Oversizing, most probably.
Oversizing, correct. This is the most common. This is the reason why we don't oversize in the aortic dissections, or trauma. What the maximum size we oversize?
10%.
Dissection.
Yes.
How much?
We don't oversize more than 10%.
Correct. So 0 to 10%. Okay. Because of oversize, you can end with that retrograde dissection. You know what the other things can cause retrograde dissection? I mean, what other risk factor can cause that? I mean, what you said is the most important one. But the second thing, if you're dealing with a connective tissue disease, like a Marfan, be very careful. That's why some people don't like a TVAR, because they have a high tendency to go with a retrograde type A dissection. So if you have a connective tissue disease or oversizing, I think the two major, blood pressure. If you don't control blood pressure, if you have high blood pressure during the procedure, very high blood pressure, I think can cause also trigger. This is the reason why when you do blood, you have to bring down the blood pressure very low. Yes. But if you have uncontrolled high blood pressure, can cause retrograde dissection. This is the thing I can, think about it as a major risk factors, So let's go through all the same option and let's go through one by one. So let's go one. First one.
more than 10% oversizing of endograft. I think this is the right answer. We'll see the
Yeah,
others.
this is the right answer. Yeah.
Yes, multiple endografts.
Mm-hmm.
That
Will not
okay.
make any effect. Will make a difference. Doesn't make a difference. Not endograft. You put 1 or 2 or 3. So that's not the right answer. Okay.
Proximal endograft stent configuration. Also
Doesn't make a difference really. Nothing. Yeah.
Proximal landing zone diameter less than 40 millimeter.
This one I don't know, but some studies they showed if you have more than 40, I don't know why. Maybe I don't know Muhammad if he knows or not, but I don't know why. But if it's more than 40, they showed it's increase your type A dissection. I don't know why. Maybe because a bigger device. I don't know why. But this is just in the papers. So less than 40 should not. If it's more than 40, yes, it will increase your, type A dissection. Okay. Joseph endograft.
Endografts.
No, nobody showed that they like Medtronic or Coke or none of them is like higher chance of retrograde. So all of them are the same.
Yes.
So as I said, the main thing is really oversizing, hypertension. I would say like connective tissue disease and size more than 40 millimeters. This is what I can say. Hamad, anything to add, or do you have any other risk factor that can cause to get type A dissection?
I totally agree with you.
Yeah,
Yes,
this is the one. Yeah.
Yeah.
Do you have any type A dissection in your practice? Ever see it or no?
I have seen it. Yes, I have seen a lot. I do sometimes with the cardiothoracic surgeon. Sometimes I do it myself, and I have seen this complication quite a lot.
Immediately or late?
I've seen the immediate one, and I've seen the one after 24 hours in ICU. And
right. Does it survive?
I have seen plenty. No, didn't survive.
Yeah.
Once you get post-operative pain, you get a lot of things, and sometimes the wire, the wire get buckled in one of the coronary vessels. Sometimes you get part of the stent in the arch to trigger one of the coronary, causing spasm, causing occlusion. It happened to us in practice. Sometimes it happened in live cases. I think in one of Link 2023, they done a TIVAR and patient arrested on table during the live. They cut the live and they mentioned the next day that one of the hooks of the TIVAR device was hitting the left main coronary vessel. That is why the patient went into a heart attack. And they were able to manage it and to put a stent into the left main stent, and they showed us the image after that. So this is one of the commonest, I'll say one of the unfortunate complications that we see, unfortunately.
Yeah. Some people also argue that remember, guys, the difference between EVAR and TIVAR.
Yeah.
In the EVAR, we don't have a hook.
Yeah.
We have a bare stent, but not hook.
Yeah.
You have to be very careful.
Yeah.
Well, in the EVAR, we have a bare stent and hook.
Yes, exactly. Yeah.
The reason why in the TIVAR, if you have a bare stent or don't have a bare stent, doesn't make a difference because there's no hook.
Exactly.
So some people, because they argue that if you have a bare stent, it may trigger a retrograde dissection. Not really. Nobody showed that.
Yes. Yes.
So
exactly.
So you don't have. So you can use a bare stent safely in the thoracic dissection, but not the hook.
Not the hook. Yes. Yes.
Yeah, that's true.
But for TIVARs, just if I may add, Cook has added a dissection stent where you don't have any struts. So they say, at least it's not maybe anecdotal, but most people who do a lot of these, they say it's try to avoid, landing struts, long struts, such as Medtronic, Captivia, has associated with more retrograde dissection. But Gore has this very short struts, and Cook has no struts.
Do you have any data to show that, Muhammad?
No.
We don't have data, as I'm saying.
I'm not aware of any. No, and I can look.
Yeah,
I'll look.
We don't have any data comparing them to say one has higher chance of endoleak, but sometimes it's just your feeling, that.
Yeah. So.
Yeah. Right. So yeah, could be. I think the other things I can think is the wire itself, really, because this is a stiff wire. If you keep playing with ascending aorta, with the wire and keep pushing, or you push the wire like stiff wire, it pull back, and you push it without like a sheet, without catheters. Or I mean, then I think you can damage the aorta and cause dissection, because it doesn't need much to cause dissection, right? So I think every time the super stiff wire like Landerquist, when you pull back, I try not to push it like in blindly. I try to put the catheter again back and then try to push it over the catheters, to be very careful. Yeah.
And also people use glide wire sometimes. Glide wire also a dangerous wire for dissection.
Yeah, that's true.
I use usually a J wire if I can, and I use glide only if I can't get back to the true lumen. But my get to go wire is J wire in this case, because you have the J, and you're not gonna be basically messing around any intimate, you know. So, but
all right, let's go back to Bara. You want to do the Bara?
Yes, Dr. Samer.
Oh, let's do that. Quick, two more
A
questions.
59-year-old.
Let's do finish time. Yeah.
59-year-old man present to the emergency department with abdominal and lower back pain for the past 2 weeks. He denies fever, chills, or chest pain. CT scan are shown.
how you doing? That's we hope. So sorry about that. You know, it's okay. And he said you're gonna punish me. I took the punishment for 2 months.
Laboratory value shows WBC count of 12,000, ASR of 46, and C-reactive protein at 60 milligram. Blood culture were positive for E. coli. Antibiotic were initiated. The best treatment strategy for this patient is?
So what is you are dealing with?
Mycotic aneurysm. This is a 59-year-old male patient with mycotic aneurysm.
Yeah. So what's the best treatment?
Open surgery.
Yeah, open repair, because especially he's symptomatic. He came to emergency. Don't sleep too long on the mycotic aneurysm, infected aneurysm, because they could rupture easy, you know. They have high tendency to rupture, so I'll be very careful. I may accept like you wait 3 or 2 maximum, but not don't send them home and bring them back, or wait like a week or 10 days, especially when they come with the pain. So what else can give you this picture is aortitis, right?
Aortitis, yes, vasculitis.
So this is 2 things, but this one you have, you know,
Positive blood culture
is positive, right? But otherwise you can think about aortitis. Aortitis is different. Then you have to treat it with a cortisone first, right? It's autoimmune. You don't jump to surgery. So it's very important to differentiate between aortitis as an autoimmune disease or aortitis secondary to the infection. Okay.
Yes.
So this one, they made it easy. They give you positive blood culture, so make it easy for you that we're dealing with mycotic, you know. Because it's thickening and inflammation, you see it also in aortitis. All right. So you do what do you do? A surgery or endovascular?
No, surgery.
Okay. What do you do? Surgery. You resect it, right? So what other
Yeah,
option? How do you reconstruct it? But how do you reconstruct it?
I will see the extension of the disease
area. You can do it. I'm saying you just give me what kind of repair. Don't worry about extension. I mean, you're just going to take it out. So you're going to do like suture it and do axillobiafilm. Are you going to do in situ rifampicin graft? Are you do like a bovine tube graft? Are you going to do homograft? All are correct. Just tell me why you want to choose whatever option you want.
I will go with rifampicin soaked graft.
Yeah, this is the most common now. They do that. Why don't do axillobiafilm and suture the stump?
The short patency rate and
what the most devastating complication of this technique?
Rupture of the stump, aortic stump.
Yeah, the stump. Right, especially with infection and inflamed tissue. So the high chance of rupture, and they die from ruptured stump. So this is the old teaching. I mean, if you do it, I'm not saying it's wrong, but it's not these days. The old day we used to do it this way, but now these days, especially you have a strong antibiotic now, you don't see much infection, you don't see air bubbles, you know. So really now most people, they do in situ repair. And then inside you have multiple options, as you said. You have rifampicin soaked graft, you know. You can use a homograft. You can use now, you can do the bovine, make it a tube graft, and you can suture it. So you have multiple options. But I think most people now, they prefer to do in situ. Okay? Repair. So let's see what options he gave you. What about endovascular before we go further? What about endovascular? Can you do endovascular?
Endovascular, I will not go with endovascular as a first option, but if the patient is frail patient and very sick to go for open surgery, I will use it.
Yeah, some people already they do EVAR now for, as you said, if sick patients, multiple comorbidity, then they use an EVAR and with lifelong antibiotics. Some people they report a very good result, even as a definitive procedure, not as a bridge. So, but as I said, it will not be your first option, but some people maybe EVAR will be the best option for them if they are too sick. Yeah. All right, let's go one by one.
So percutaneous biopsy of the periaortic inflammation, no, I will not touch it.
Yeah, may rupture, so I will not do that.
Yes. Open repair with replacement of the aorta with in situ rifampicin soaked Dacron graft. This one I think correct. Endovascular aortic aneurysm repair, it is not my first option.
Correct.
Ligation of the aorta with axillo-fem bypass. This is also not the first option. And antibiotic therapy for 6 weeks with follow-up CT scan. No.
All right. But I think this in the exam is not the fair questions because some people, they may still do a ligation and axillo-fem bypass. I don't think we can play this is wrong. I may not do it, but doesn't mean wrong. So I don't think they should put it this way because if somebody chooses this one, then they're going to make him wrong, which is I don't think should be wrong. Hamad, what do you think?
Yes, I totally agree. This is debatable point. There is multiple strategies. It is evolving, and we don't have, let us say, grade A recommendation. What is the best answer for this? I totally agree with you.
What do you do, Muhammad, when they have infected? What kind of repair you do? What kind of graft?
Yeah, the best one is to get the infected graft out, and this is according to the guideline for aortic graft infection and aortic infection by the American Vascular Society. So, but the problem that many of the patients that I see them, they are very, very unwell. They are not fit to have this procedure. So the best treatment is open, but mostly they are unfit. So we usually do PET scan to decide the area of inflammation of the aorta, and we see if there is an endovascular option under umbrella of heavy antibiotic just to get the patient better. But some of them can improve in endovascular management on occasional with the successful antibiotic treatment, but some of them doesn't. And they still have a high mortality. The one which do a lot of endovascular to aortitis and aortic infection is a consultant from St. Mary Hospital called Marianne. He has a big series of endovascular management of infected aorta. He done, I think, about 75 cases. But this is what I basically do. If they are fit, I do open. If they're unfit, I do endovascular, antibiotic, follow-up and culture and PET scan. If they are get better, then we can go back to open. If they don't improve, they just gradually go downhill.
I think Dr. Murad Salam is the one who has also large series.
Yeah.
Was the infected graft.
Yeah.
And I was talking to him one time. He has a special protocol, which I think is a very nice protocol.
Yes.
I mean, still, if he has to go to the vascular, he put a graft and put patient an antibiotic for 1 year.
Yes.
And after 1 year, he stops the antibiotics. If the infection recur, then he treats it as an infected graft. He just go and take him out.
Yeah.
If patient did fine, then he stops the antibiotic.
Yes.
This is his protocol, for infected graft.
Yeah, Murad Salam in Guy's Hospital.
Yeah.
His interest is the algorithm of aortic infection.
Yeah.
And there is
It's a very nice algorithm, by the way.
I don't know. I asked him, why did you like this topic out of all vascular options? This is the thing that we run away from. What do you say, Dr. Muhammad?
Yeah.
For me, I do quite a bit of these too. You know, not a lot, maybe not as much as Murad does, but I do a few a year. So you know, they're a little bit hard, and you know, you have to have sometimes two teams. I don't do NACE procedure because NACE procedure is very morbid. You know, some people have compartment, and it takes a long time. Like Dr. Samer said, you know, you can use a allograft or homograft if it's available. We have it on the shelf, but then you have to watch these patients because they can develop, you know, aneurysmal dilation. And then the other thing is you can use a regular graft like Safi. You know, Dr. Hazem Safi, he uses just a Dicron graft that you know soaked with rifampin and wraps it with the omentum, and he has a pretty good data on that. The DRCR are difficult surgery, but the one thing I wanted to let the fellows know is, you know, if you can do this with insight or reconstruction, it's much better. If you like it, the aura and do a XFIM, you know, there's a blowout rate is like 40% of the aorta later on. So and if you're there already, you half the work is done, you know, so you might just replace it, you know, so.
Recently, we moved from homograft, Muhammad, because the generation we saw later on. Now we use bovine patch. We make it like a tube, and really we feel
Sure.
good. I don't know if you do that or you have experience with
No,
bovine.
no, I don't have. Actually, I learned about it from you guys in the on the WhatsApp group. I never.
It's very nice. It's very strong and very easy to use it and configure it. You know.
Yeah,
and,
no.
Yeah, maybe I should put the figure how to do it and how you can put it on the group. Can look at it.
Yeah, it would be
very
nice.
Simple. Just table it and you put it there, and it's nice to work fine, and you don't have to wait for homograft. And Muhammad, did you use it, Muhammad? Omar?
No, I don't use it. But my son in United Kingdom, he used it. I told him, what do you do in aortic graft? He told me we only use bovine. He doesn't use anything else. But in Egypt, we don't have bovine. We use rifampicin. Rifampicin impregnated synthetic graft or silver impregnated graft. It's not a good option, but sometimes it can buy you time. But bovine, I think, is getting very popular.
All right. I think let's stop here. This question about, I think, trauma. So we can start trauma next. Is that right? Or it's fistula?